So welcome everybody to today's presentation of our Family Medicine Grand Rounds. If you are looking to claim CME credit, please make sure that you do text the activity code to the toll-free number listed there for today. Make sure you do that before midnight tonight. And I'll go through some more information here on the next screen for those who may be new. So if you have not yet registered, you need to text your email address first to the toll-free number listed there. And then once you have done that, you can then start using the system. You will just text attend along with the code for today's session, which is listed there for you. Next slide.
Oh, sorry.
That's okay. I'm going to make sure as we get started here, if everybody could please make sure that you are muted, that your microphone is muted. Also, please be engaged and attentive to the session. We will be taking questions in the chat box and we'll go over those at the end of the presentation. Also, if you can help us out, I will put a link in the chat box towards the end of the presentation, but if you'll help us with providing feedback for our presenter today. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central Area AHEC, and then you can also see our mission statement there. Next slide. CME transcripts are available if you choose to claim CME credit and you need to take a look at your transcript. You just need to go to the CME office website listed there for you. If you do have any issues with that though, please feel free to reach out to them or you can contact myself as well. Next slide. For this presentation, we do also offer AAFP credit for those who are interested or who are members. You do need that CME transcript to submit in order to claim the credit, but if you have any questions or issues, feel free to reach out to them or you can contact me as well. Next slide. We also want to make sure that we point out that it is the goal of our Grand Rounds presentations to address the nationally established physician core competencies that you see listed here. Next slide. And so for today, Dr. Nicole Vargas and Dr. Miguel Palacios have no financial relationships with ineligible companies to disclose. And Dr. Vargas is one of our third-year residents here in the department. She is going to be discussing HPV vaccination and the risk of invasive cervical cancer. So I will let her start.
Thank you. So like she said, we're going to be talking about HPV vaccination and how it's related to invasive cervical cancer. The objectives today are to review the study results and see how it applies to primary care, and then review the vaccination schedule. So what is invasive cervical cancer? So it first starts as a HPV infection at the transformation zone of the cervix. And after a persistent infection, their precancer is formed. And then after that, considered carcinoma and an invasion through the basement membrane. So the clinical manifestations are kind of non-specific. It's irregular bleeding or heavy bleeding and postcoital bleeding. So the purpose of the study has been shown that in previous studies that HPV vaccine protects against HPV infection, genital warts, and high-grade precancerous cervical lesions. But the question is, does it protect against invasive cervical cancer? The study used a Swedish National Database to collect the data. So in Sweden, the vaccination schedule started in May of 2007. They began to offer the HPV vaccination to girls 13 to 17 years old. And then in 2012, they offered a catch-up vaccination program to girls 13 to 18 years old and a school-based vaccination program to girls 10 to 12 years old. And in Sweden, cervical cancer screening is offered to women 23 to 64 years old every 3 to 7 years, depending on the age of the woman and the results, I'm sure. So the vaccine given there was a quadrivalent HPV vaccine that covers subtypes 6, 11, 16, and 18. And from 2006, it was a 3-dose series but starting in 2015, they started to offer the 2-dose series for a school-based vaccination program. So the inclusion criteria for the study was first to be a woman, and the data was collected between 2006 and 2017. Women had to be 10 to 30 years old. They had to be living in Sweden at the time of the study, no previous HPV vaccinations given, and no previous invasive cervical cancers in their history. The endpoints that were looked at were the women were followed until they either received the diagnosis of invasive cervical cancer, they immigrated or left Sweden, they died, they were lost for follow-up in the registry, they received the bivalent instead of the quadrivalent HPV vaccine, or they had their 31st birthday. So any of these things kind of excluded them from the study. So as you can see from this flow chart, it started with over 2 million women. After some of the initial exclusion criteria were met, they were left with about 1.6 million who had no previous history of invasive cervical carcinoma or anything like that. And then after some additional exclusion criteria were met, they were left with just a slightly smaller, basically still 1.6 million people. And those were divided into those who had received the vaccine versus those who had not received the vaccine during the study. So of the 1.6 million women from 10 to 30 years old, those who received the vaccine included a little over 500,000. Of those 500,000, 19 were diagnosed with cervical cancer. In the unvaccinated population, there was 1.1 million of those people. And in that subsection of people, there were 538 who were diagnosed with cervical cancer. And this chart shows kind of the population broken up into the years that they were born, if their mother was from Sweden or another country, the parental education level, the annual household income, maternal history of CIN 3+, or maternal history of non-cervical cancer. So as you can see, in general, they're mostly pretty well matched between the two groups. There's not a huge difference between the two groups. And this chart shows it kind of breaks down who got cancer based on when they got their vaccines, which I'm actually going to describe a little bit more in the next slide. So it shows that cervical cancer has a cumulative incidence in the unvaccinated population of 94 cases per 100,000 people by the age of 30. And then the vaccinated population, there are 47 cases per 100,000 people by the age of 30. This is further subdivided into when they received their vaccination. So if they initiated their vaccination between age 17 and 30 years old, there was 54 cases per 100,000. And if they initiated their vaccination before the age of 17, there was only 4 cases per 100,000. And this graph just basically shows what I just said. So the conclusions of the study are that the quadrivalent HPV vaccine have reduced risk of invasive cervical cancer. And those who initiated the vaccine at a younger age, so less than 17, had greater benefits of reducing the risk of invasive cervical cancer. And vaccination prior to HPV infection is the most beneficial, which we all kind of know that. And the question is herd immunity. So previously in Sweden, there was shown that genital warts decreased due to herd immunity with the HPV vaccine. So the question was, does the herd immunity decrease cervical cancer? It doesn't seem like there seems to be any significant data showing that there's herd immunity reducing the risk of cervical cancer. But it's possible this is because there wasn't enough time given to observe the data, as it takes 5 to 20 years to develop cancer, or the carcinoma, the invasive cervical carcinoma. So it maybe if more time was given, they'd be able to find that there's some herd immunity. Who knows? So the limitations of this study is that there was a small group of vaccinated women who were misclassified as unvaccinated. They potentially vaccinated women may be generally healthier than their unvaccinated counterparts, and lifestyle risk factors that have been known to be associated with risk of cervical cancer were not accounted for, such as smoking status, sexual activity, number of sexual partners, contraceptive use, obesity. These kinds of things have been shown to be at an increased risk of cervical cancer, and those were not accounted for. And then vaccinated women generally have a higher rate of cervical cancer screenings done, so therefore the risk of reduction may have actually been larger. So the vaccine schedule can be given to males and females. Usually it's offered between 11 and 12 years old, but you can actually offer it as low as 9 years old until 14. And if they start at that age, between 9 and 14, they only get 2 doses. The first dose would be your mark of 0 months, and the second dose would be given 6 to 12 months after the first. And then if they initiate between 15 and 45 years old, or they're immunocompromised, they would get a 3-dose series. So again, the first dose would be the 0-month mark. The second dose would actually be given 1 to 2 months after the first, and the third dose would be given 6 months after the first. Oh, sorry, after the second, my bad. So to decrease invasive cervical cancer, vaccinated women did show a significantly less instance of cervical cancer, especially when they initiated their vaccination at a younger age. And it can be easy to miss giving a HPV vaccine, especially in adult clinic, because it's usually considered like a child vaccine, and so it can be assumed that they're given that as a child, but that may not always be the case. And in EPIC, there's no healthcare gap. It doesn't always come up as a healthcare gap and that they're missing their HPV vaccine, especially when they're a little bit older. I had a 24-year-old yesterday who had actually said it, but usually my 30s and 40-year-old patients, that doesn't always say that. So I do think that that's something that EPIC does miss. There's not many other vaccines or medical problems to deal with. Or sorry, there's too many other medical problems to deal with in our population. So often you don't think about giving them the vaccine because it's just one more thing to deal with whenever they have sugars of 800 all the time. And then there's a stigma of this vaccine. The Gardasil has a huge stigma against it. Several years ago, a lot of people didn't want to give it to their kids. And truly, I'm unsure if our clinic has the vaccine on a regular basis, and if it's in stock, and there's always a funding dilemma of, do they have the vaccine for the CareLink patients or the private pay patients? So for our residency, at least, those are the potential problems. So in summary, the invasive cervical cancer starts with an infection. It's due to the persistence of the infection, creating precancer and then cancer with invasion. HPV vaccination decreases invasive cervical cancer, and the vaccine can be offered to men and women 9 to 45 years old. These are my references. Any questions?
I don't see any questions in the chat box, but if anybody wants to unmute or put anything in the chat box, please feel free to do so.
Hi, Nicole. Can you hear me?
Yep.
Okay. I have a question. I guess I was under the assumption that this type of study has been done already in the past, because I've been educating my patient to prevent cervical cancer. Was that an indirect association before this study? Is this the very first study that showed the prevention in cervical cancer?
I don't know if it was the first. I think that we kind of assumed it did, but not necessarily the invasive part of it, like that it prevented the precancer. I don't know if it was the first or not though.
Nicole, it's Dr. Nato. So if you give a COVID vaccine, it might prevent it, or it might make it less severe disease when you get it. Was there evidence that for those who were vaccinated who actually got the cancer, that it was less invasive, or was it similar, or did you run across any information about that?
I did not, but that's a really good question. And I don't know if I've ever even heard about that, like when I was rotating in OB-GYN and stuff like that, if I've ever heard that, but that's really interesting to think about. I'll have to look it up. I'll let you know.
And Dr. Eustace had a couple of questions in the chat. First one was about the Gardasil. What was the stigma?
So whenever it came out several years ago, there were a couple of girls who got the vaccine that had negative side effects from it. One of them basically reverted, and she was like 12 or 13 and basically became a child that couldn't accomplish anything. And that was widely spread across different forms of media. So that was one of the biggest ones, was that that girl's experience. And then there was a couple others, just like any vaccine, people can have reactions to it. And whenever it came out several years ago, there, bad news makes good news, right? So it talked about a lot of the bad reactions. Just like whenever the COVID vaccine came out, everyone talked about all the bad reactions to it, but less so now.
The other question there was, does CareLink cover it or not?
Sorry?
Does CareLink actually cover the vaccine?
I don't know. I would assume. I offered it the other day to a CareLink person, so I hope so.
This is Dr. K. There was another stigma when Gardasil came out, and that was the evangelicals were claiming your child was going to be more promiscuous if you gave her this vaccine.
Yes.
And I will say in the Well Child Clinic, that's the biggest conversation that I tend to have with parents, because we offer it at 9 years, at 11 years, and many parents are just not ready to have that, your child may have sex one day conversation. And so it shuts it down pretty early. So talking to them about it doesn't open the door for them to have sex, which is something I keep hearing. It's a every Well Child Clinic, we have to discuss that.
It's interesting, we can now tell them that there's at least some data to show if you get the vaccine earlier that it's more protective. Without getting into that question.
Yeah, I also found, can y'all hear me okay?
Mm-hmm.
That those commercials were really effective. The did you know, mom? Did you know that? Because I've had a couple of parents reference those series of commercials about the HPV vaccine. So I thought that was a really good campaign to kind of change the perspective from which you're coming with it, because I do think that was the main stigma that I was confronted with too, whenever offering it in Well Child, about the fact that it's related to being sexually active. So that was just my 2 cents. That was a good example of good media, in my opinion.
Those were really good commercials. They actually made me cry once.
Do you have any other comments or questions for Dr. Vargas? Well, with that, we'll go ahead and end the meeting for today. I did put the link for feedback, if we can provide feedback by completing that evaluation. But if everybody would have a great day, and that'll be it for today. Thank you, Dr. Vargas.
Thank you.